Hello.
Hello.
Hi.
I thought I would come on early, thinking the others would be here. So I don't know.
Yeah.
I'll text them. I'll let them
Okay.
know that you've opened up the room. Thank you.
Yeah, of course.
Oh, Gretchen says that she's waiting to be
Yeah.
admitted.
I just got the alert that she's in. Okay. Sometimes it's slow in giving me the notifications, so apologies
Yeah,
for that.
no
And
worries.
do you want me to make you each of you a co-host?
Sure.
Okay.
Hi,
Hi, Maria.
Gretchen.
Hi, Gretchen. Nope, that's wrong. That's not what I meant to do.
I may just try to screen share to make sure I have everything set up so
Of
it's
course.
on the right screen and all that good stuff.
There we go.
Thanks. I don't want to see snow again for a really long time.
I was gonna say, how cold was it? Okay, don't
Oh,
have the right screen share.
breathing.
Uh,
Oh, but you made it back. Good job.
Was driving like 80 plus, but yeah, I made it back
you drove? Oh my goodness gracious.
from San Francisco. Yeah.
Okay, from San
Oh,
Francisco. I thought you meant like from DC, and I was like, how in the world did you
no,
do
no.
that?
Oh my God, no, no.
Was
That's
it a
weird.
good turnout?
Yeah, I mean, it was okay. Um, it was peaceful.
Mhm.
So it was very peaceful. They blocked off so much of the area, like National
Yeah,
Mall and everything, and
yeah.
a lot of them went to that the arena that he
Uh-huh.
had set up. Which, you know what? Thinking about it, a lot of people were complaining. It probably was a good idea that they did that instead of having all those people outside in the cold.
Yeah,
So
yeah.
he did do something nice.
Yeah.
Yeah, I kept myself in a little bubble for a couple days, and then yesterday I was like, all right, I'm going back to work. So bring on all the current executive orders and whatnot.
Yeah.
I know. I know. I had this just like this feeling of panic all morning, and I was like, "Oh, I'm gonna have to figure out how to manage that because it's gonna be 4 years."
Yeah,
Yeah.
All right, are you seeing my, no, you're not seeing my
I'm
PowerPoint, are
seeing
you?
your Outlook.
Oh, fabulous. Okay, so I do need to keep, okay.
It's okay, I'm not screenshotting.
My calendar, it's very exciting. Yes. Okay. Let's get this reorganized here. Okay, how does that look?
Yep.
Yeah.
Okay, fabulous. Thank you.
I was going to ask with questions and answers, do you want those throughout? Do you want folks to hold them?
I like them throughout.
Okay. And then intros, are there specific pieces you want me to outline or just basic control panels and turn it over?
Yeah, I mean, I think
Okay.
we have an introduction slide, but it's kind of more just for folks to refer back to. Maybe we're just all CalAIM specialists. I don't know what the right term is. Allison Belgique,
I'm sorry.
subject matter experts.
Oh, no, I don't like that term at all.
Okay, well then what would you prefer, Belgique?
I can hand it on over to our CalAIM
To
webinar
me.
for event centers. Yeah, to Gretchen. Okay.
Do you want me to put the slideshow up now as we let folks in, or wait until we start presenting?
I just had a question. Do you guys have a land acknowledgement at the start of yours?
We do not. Would you like us to
Okay.
put that in? Or do you want to do that?
I can do that really quick.
Okay, great.
Because I have a webinar template that I can use really fast.
Okay, perfect.
Thank you.
Okay.
And then Miranda, you're going to get the AI transcript from this, like that takes notes.
Oh, do you want the AI transcript on? Okay.
Yeah, and then is there a way that we can get a copy of that when it's
Yeah,
done?
absolutely.
Great. I'm going to try and take notes as we're going, but sometimes I don't capture it all.
Uh-huh.
I guess, Belgique, for questions that come in the chat, I don't know if they're worth discussing, if you want to not answer them in the chat and then just flag them for us, or what's working best for you.
You're muted, Belgique.
I'll see if it's something I can answer. I'll flag you.
Okay, perfect.
Yeah.
I think too, just depending on time, at the end, I'll open it back up for questions, or if we're running low on time, then I'll just let folks know they can put questions into the survey at the end.
And sorry, is it just the AI companion that you turn on? I don't use it.
No, so after the meeting, yeah, that's all you do is turn it on. It normally turns
Okay.
on automatically. And then after the meeting, after it's done capturing all the notes, it comes in your Zoom account.
Okay.
Yeah. I think sometimes there's a way that I can ask to get a copy of it, but nobody's ever sent it to me after I've asked for it. So see.
Just open it up. It's really interesting because you can use it like on your own too. Like, and you can
Hmm.
say, "Catch me up." Was my name mentioned? Kind of cool.
Right. So,
Yeah, when I hit transcript, it gives me the whole everything, and then I can save it at the end of the meeting. And then I'll start recording once we have folks doing. We have folks who are usually pretty early, so I'm a little glad they haven't jumped in this yet.
All catching up from our weekend off.
Yeah.
Allison, were you traveling somewhere too?
No, I just realized that I'm traveling on March 10th, which is why we had to shift that one.
Gotcha, gotcha. Okay.
Yeah. Yeah, no, I was home this weekend. Were you traveling?
No,
Oh, okay.
no, I have
Okay.
a kid going back to college tomorrow, so I've been trying to soak up time with her before she leaves me.
Nice.
Yeah,
Nice. That's great.
yeah.
What school is she in?
She's at Smith in Massachusetts.
Mhm. Cool.
She loves it. She's missed it the whole time. And I'm like, oh, can't you miss home too?
Where is? I was just going over the run of show, looking at where I need to
Hmm.
put the links, and I can't find one. The Medi-Cal managed care fact sheet. What slide is that on?
That's when we go over the managed care models
Managed care models.
under CalAIM overview. So we talk about how they have COEs or GMC.
Oh yeah,
Need to
right.
find out what model your county
Oh,
has.
there it is.
Okay. Oh, you're
See,
putting the slide numbers in smart.
yeah. Actually, so the link isn't on that slide. It just has the plans by county. If you go to slide 12.
Right, right. That's what we had the link. We can just dump it in for folks to look at.
Okay.
I just want to make sure the slides are still clear for y'all. Be able to see them.
The control panel, yeah.
Okay. Yeah, it's just a control panel and then the land acknowledgement, which I can do really quick, and then we can switch over.
Hi, Jennifer.
Hi everyone, how are you?
Good.
Hi.
How are you?
Doing good.
Good.
Doing okay. Um, I had a question. Now it'll come back to me. It'll come back. I know what I was gonna ask. Did you all have a post assessment that you wanted us to put in the chat or send out after?
Yeah,
That was my
we ended up just going with a survey in Google Forms, and so we'll throw it into the chat when we get to the end.
okay. All right,
Yeah,
cool.
thanks for
Thank
checking in about that. Yeah.
Are we good if I start letting folks in, or you want me just to wait another moment?
Yeah, fine.
Okay. I'm not going to get us started yet, just getting folks in. Good sense. Welcome, everyone. We'll be starting in just one moment. Jen, if you can just keep an eye on the waiting room for me and letting folks in. All right. Welcome, everyone. My name is Miranda Stiers. I am the Associate Director of Prevention and Capacity Building here at the Partnership. Today's webinar is being recorded, and we will be sharing that out afterwards. Just wanted to go through some quick housekeeping. I know we're all very familiar with Zoom. Just making sure you can mute, unmute, you can have your video on or off. Um, you can also see who else is here and chat. You can chat directly to the facilitators. You can also chat us if you are having any kind of challenges with your audio, etc. We have closed captioning enabled, and we're very much looking forward to getting this conversation started. Before we get started, I want to acknowledge that I am joining from the lands of the Nisenan, Miwok, and Maidu people here in Sacramento. Um, we know that California is home to more than 120 federally recognized tribes and many others who are seeking recognition and acknowledgement of their work. We keep these nations in our hearts, and I want to pass it on over to Gretchen so we can get started.
Great. Thank you, Miranda. Hi, everybody. Nice to see you. Welcome. Great to see you all on camera. I'm going to now share my screen, and hopefully I will do this smoothly. All right. Let's see. Is it working? Do I have the right screen up? Okay, hopefully. Good. Great. My name is Gretchen Schroeder, and I will be co-hosting our CalAIM Essentials webinar today. It's great to see you here. My co-presenters are going to be Allison Tudor and Baljit Hundal, and you can read more about us on our intro slide, but just wanted to do a quick hello. Maybe Allison and Baljit, you can wave a little bit. Okay, great. And now I want to find out more about you guys. And so I would love it if you all don't mind putting your name and organization in the chat for us. And then we're going to do a little poll to see what your CalAIM experience is so that we can hopefully address our content to you guys appropriately. So we're going to launch a poll here just to find out, are you a CalAIM expert? Are you a CalAIM novice, or are you, and this is my favorite term, not coined by me, by some other facilitators, about are you CalAIM curious? Are you still learning about CalAIM and don't know enough to be either an expert or a novice yet? So go ahead and thanks for launching the poll. Great. Thank you all for introducing yourself. And is the poll slowing down? All right, so we can go ahead and launch the results. So I'm excited that we have two experts in the room. So feel free to jump in here if you have things to add. And we have a lot of folks who are CalAIM curious. So that's great. So we'll walk through things today. Actually, I can go to my slide about our agenda here. So we can start to talk today about some of the big picture items around CalAIM. So we'll do a nice overview of what CalAIM is and some of the initiatives that run underneath it, and also talk about why in the heck the state launched this program. Then we'll also go into enhanced care management and do an overview of that, what those services are, and thinking about how they may or may not be a benefit to some of the folks that you work with. We'll also look at community supports, and same thing, do a high-level overview of the 15 community supports that are currently approved in California. And then my favorite section is always around financing. So talking about what does that look like? What are some of the payment models that managed care plans are using for these services? What are some of the considerations you may want to think about as you look at trying to finance your programs, and how ECM and community supports may or may not fit into that? And then we have this very generic section called considerations here. And these are some topics just that we want to have more of a conversation about and think through how this may apply to you and your organization and the folks that you're serving. So we have a couple of great things around staffing, around IT, around data sharing and confidentiality. So we'll be jumping into that towards the end of our webinar here today. And then we do have some things for next steps to help you all think about ECM and community supports in more detail. And we have some additional webinars that we're going to be hosting, so we have some more information on that. With that, we are going to jump into our CalAIM overview. Before I go into the details here, the state does use CalAIM and Medi-Cal transformation interchangeably, so I will also be doing that too. They've tried to rebrand CalAIM a few times that have not been successful, but they do call it both CalAIM and Medi-Cal transformation here. Just to do a level set here, I don't know how familiar with all of you are with Medi-Cal, so we'll just do a quick review of that. Medi-Cal is California's Medicaid program, which is a public health insurance program that provides needed healthcare services for qualifying individuals. California is much more generous in terms of the services it covers and the populations it covers under Medi-Cal than what's required by the federal government. So that's something important to know as we look at budget changes and federal policy changes. We may see some fluctuations in what services are covered and who's covered under Medi-Cal in the near future. But right now, eligibility, it's really targeting low-income Californians, which include families, single adults. It does include seniors and persons with disabilities, and of course, foster care and pregnant women. And then there are also some specific diseases and conditions that will also qualify an individual for Medi-Cal. So it is broad ranging, and it's important just to be aware that you really have to check someone's eligibility to understand, do they have full scope Medi-Cal? Do they only qualify for certain Medi-Cal components? That's an important thing to think about as we start talking about CalAIM here. Financing. So as I look at this slide, very simply, Medi-Cal is financed 50% by the federal government and 50% by California. However, there are certain populations where the federal government pays more. You may recall a few years ago, we had the expansion population for Medi-Cal, trying to really expand Medi-Cal to higher income individuals and families. And for that population, the federal government pays 90% of the Medi-Cal costs, and California pays 10%. We also in California cover undocumented individuals under Medi-Cal, and for that population, California pays 100% of the costs for those individuals. So it varies, but very simply, just for this purpose, we'll think about Medi-Cal being funded 50-50 by the feds and by California. Enrollment. So in California, it varies a little bit, but month to month, we see about 15 million individuals who are covered by Medi-Cal. Now, what's important is about 90 to 95% of those individuals are actually covered under Medi-Cal managed care. So as a state thought about making these changes to Medi-Cal, transforming Medi-Cal to be a stronger, better program, they decided to do it through the managed care network because that is where most folks are enrolled. Not everyone, but 90 to 95% of folks who are in Medi-Cal are in managed care. So all of these changes under CalAIM have been rolled out through the Medi-Cal managed care plans, which has been a challenge and an opportunity for all of us to get to know our managed care plans better and to really start to bridge some gaps in our healthcare system. Any questions right now on Medi-Cal before I go on? All right, good. Maybe you all know all about Medi-Cal, which is great. All right. So why did the state decide to transform Medi-Cal? So I think there are some driving factors here. One of them is that we know in Medi-Cal there is a population of folks who have really complex health conditions. And to meet their needs, they're trying to access multiple systems of care, behavioral health over here, medical over here, dental over here. And it's really challenging for them to get the care they need and to manage it all. And so we know these multiple delivery systems often don't talk to each other, often don't coordinate care, so it becomes really, really difficult. And we also know that a lot of these folks are some of our highest cost individuals. So in Medi-Cal, about 50% of our Medi-Cal spending is tied to 5% of the Medi-Cal population. So as the state rolled out CalAIM, most of these programs are targeting that 5% of the Medi-Cal population with the highest needs and who have the highest costs. So that's who we're thinking about as we talk about CalAIM. So the goal for CalAIM was to really address these issues, and then they set about some pretty lofty goals here as well for CalAIM to address. One is to really address California's physical and mental health needs, and to really try to, coordinate those services together. The state wanted to improve and integrate care for Californians, so really trying to have systems talk to each other to coordinate care across the silos. And then be a catalyst for equity and justice. And so hoping that as we try to employ some of these transformations equitably across the state, we're going to get more or closer to this equity and justice focused system. And then the big piece that we're starting to see some results from, which has been really exciting, is we're wanting to build a healthier state together. So we're trying to break down silos, bring folks together. As I mentioned, managed care plans are now part of a lot of our conversations where they may not have been 5 years ago. So trying to really break down these barriers and silos and have folks work together towards these common goals. In addition to the goals that we just laid out, the state has set some really bold goals here. They're supposed to try to achieve by 2025 this year. And again, these are really targeting managed care plans. So how do we close the racial and ethnic disparities gap in well child visits and immunizations? How do we close maternity care disparities for Black and Native American persons? We want to improve maternal and adolescent depression screening, improve follow-up for mental health and substance use disorder. And we really want to ensure that our kids are getting all of their preventative care measures met. So these are goals that the state has laid out, and I know budget is tight, but if we can, work on trying to meet these goals, the state is going to continue to provide funding for the programs that we're working on. So that's been something to kind of look at and focus on going towards. Any questions on these bold goals or CalAIM goals? All right, we'll just keep going. So CalAIM is an umbrella. It's a kind of a waiver the state has put together, and there are 11 initiatives that are underneath CalAIM. Most are driven through the managed care plans, though not all. And we are only going to focus on the four on the top row today, which includes enhanced care management, community supports, incentive payment program or IPP, and then what's called the PATH initiative, or providing access and transforming health. And both IPP and PATH have a lot of financing and funding available for folks who are doing ECM and community support. So we'll jump into that later on in the training. So just to give you a sense of how CalAIM and ECM and community supports are structured, the state rolls out the policy for these programs. They have these guides, which we'll put in the chat as we go through each program. And they're doing quality and oversight of our managed care plans to make sure folks are doing this correctly. But they really leave the rest of the operational components of ECM and community supports to our Medi-Cal managed care plans. So as we look at how do we get involved in ECM, how do we get involved in community supports, we are going to be working mostly with the Medi-Cal managed care plans in our county. And so one of the things we'll talk about a lot today is how do we get to know our MCPs, our managed care plan partners? How do we work with them? What does it mean to contract with them? What does it mean to bill for services for them? And so we'll be looking at that today. Now, I mentioned earlier, the state's also doing some quality oversight. Auditing is another word for it. And currently they are doing that with the Medi-Cal managed care plans. We're just starting that actually this month here for ECM and community supports. And the intent is really the state will set out these standards for quality oversight, and the managed care plans will be doing the work with their providers to make sure things are running smoothly. Any questions on that? Alrighty. So in California, we have many different Medi-Cal managed care plans, and we have very different models that are being implemented in the counties across California. But very simply, there's two types of Medi-Cal managed care plans operating in California. One is commercial health plans. We think about Anthem, we think about Health Net, think about Kaiser. Those are big commercial health plans, and there are currently 5 that operate in California. We also have what's called local health plans, and there's about 17 of them in the state, and they actually serve over 70% of the Medi-Cal population in California. So they're really important players. Some of them, like Partnership Health Plan, work across multiple counties in the northern part of the state, and some, like Santa Clara Family Health Plan, only serve Santa Clara County. So it really depends for these local health plans what the reach is for them. And that, of course, will impact probably how they're operating their ECM and community support services. We also have different models for managed care across the state. And I've given you all of the state information here. And I know Baljeet has dropped into the chat a fact sheet, which will tell you what model your county currently is under for Medi-Cal managed care. But essentially, we have a model that is what's called a COES, or County Organized Health System model, which is generally one health plan that is operating closely with the county. We have 2 counties, Sacramento and San Diego, that have to work with multiple Medi-Cal managed care plans, and they're all commercial, so that can have its own set of challenges as we think about trying to coordinate with 4 different health plans in Sacramento. And then, of course, we have counties that have 2 plans, that have a regional model, and that have a single plan model. So in addition to these models, we also have Kaiser, which has a unique contracting relationship with the state, where they are often in most of these counties, but may have a direct contract with the state and may not be working in the same model that the other health plans are. Any questions on managed care? All right, we'll just keep going. So let's jump into ECM here. So enhanced care management was rolled out in January of 2022, and it's really trying to provide that intensive care coordination that folks with complex health conditions, high needs, trying to work across multiple delivery systems, they need support in doing all of that. And so it's really, the important thing here is it's a Medi-Cal benefit. So ECM is something that is not going away. It is now part of the benefit package for Californians under Medi-Cal, same as getting a physical, for example. It is a Medi-Cal benefit. So the Medi-Cal managed care plans are paid more to do ECM by the state. So that's an important thing to think about as we talk about rate negotiations for our ECM providers. ECMs intended to be a high-touch, interactive, primarily in-person model for doing care coordination. And we're really targeting the 5% of Medi-Cal managed care enrollees who have that high complexity, high need, really need support in getting across to all of their healthcare services. We also, if you look at on the right-hand side of our screen, we have what I call a pyramid of continuum of care. So ECM is targeting our top 5% of folks, our neediest, most costly folks for care coordination. But we also have what are called step-down programs for folks who may not need that high level of care. And these are all, again, all through managed care. So we have complex care management. These are for folks that have medium or rising risk for their healthcare needs. So maybe they're not that top 5% yet, but they may have been recently diagnosed with a condition that needs a lot of care coordination. So managed care plans offer programs to help support with that. And then we also have kind of our lowest level of care coordination, which is our basic population health management. If you're in managed care, you probably take advantage of this. We get to go and get health education, stop smoking, how to eat healthy, all that good stuff. That's part of our basic population health management services here. The other interesting thing that we're going to look at too as we talk about ECM is we want to help folks transition between different levels of care. So if someone's gone into a hospital, we want to help them transition to a level of care that's more appropriate as they are discharged. And so ECM is also targeted to help with those services and those transitions. ECM has been rolled out by population of focus across California. In January, when the program launched, January of 2022, when the program launched, they started offering ECM to individuals who were experiencing homelessness. That was the first population of focus to roll out. And then most recently, in January of last year of 2024, they launched the last population of focus, which was the birth equity population of focus. And that's for individuals who who have additional gaps and disparities in their maternal and postnatal care. So you can look at these different populations of focus and see, is it for both children and youth and adults, or just for adults or children and youth? And the important thing is that when we refer someone into ECM, we have to identify which population of focus they qualify for, they fall into. And I know Baljeet has dropped our policy guide in here for ECM into our chat, and that has great details about what are the qualifying conditions for each of these populations of focus. So as we think about making referrals to ECM, becoming an ECM provider, we can see who maybe we're already serving would qualify for ECM, or who we may want to make referrals for ECM services. Now, how do we make referrals into ECM? How do we get the folks that we're serving into ECM if we think they qualify? And there are three primary routes that folks get referred into ECM through. One is that the managed care plan looks at all the data, tries to run all the eligibility criteria and see which names pop up. That is what's been happening a lot, and that is not the most effective way to do things. So that was a great way to start the program off, but now we're trying to move into the other methods for getting folks enrolled into ECM. And that is really having providers out in the community or community-based organizations, churches, food pantries make referrals for individuals into ECM. So that is what the state is hoping will become the most common method for getting folks into ECM. And the last route is that individuals or their families can refer someone into ECM. So that is another way to do that. Typically, the process is that you make a referral to ECM. There's a form you fill out. You have to support why we think they qualify for the population of focus you're referring them under. And you refer them to the managed care plan, who then may take up to 5 days to review the referral and either accept someone into ECM or reject the referral. So that is very simply how ECM operates across the state. Now, we do have some managed care plans who are turning referrals around in 24 hours and some that are kind of pushing that 5-day boundary. So it's not consistent across the state how long it may take for someone to do that. Any questions on referrals into ECM? Well, we put together a small case study just to kind of talk through some of the ways that folks may qualify for ECM, some of the folks that you're working with, how it may be able to help them. So we have a case study of Pamela, and Pamela is a survivor who is living in your shelter and struggling with addiction. Does anybody have folks this sounds familiar that you work with? And so for ECM, we think that Pamela may benefit from some care coordination through ECM. So we need to figure out, how do we help Pamela access these services? And this can be accessing ECM at another provider. It could be if you want to become an ECM provider, how do you get them enrolled into your ECM program? The process can all be the same. And so for ECM, the first thing we want to do is find out if Pamela is enrolled in Medi-Cal managed care. And this can be challenging, especially if you are not a Medi-Cal provider or an ECM provider, because you need to be able to look up Pamela's Medi-Cal status. And if you're in a county that has more than one managed care plan, you need to know which Medi-Cal managed care plan that Pamela is enrolled in, so you know who to make the referral to for ECM. You will also need to identify which population of focus Pamela may qualify under for ECM. And Pamela may qualify for multiple populations of focus based on what her needs may be. But the important thing is you need to provide documentation to support one population of focus. So if we look at Pamela, we know that she does not have stable housing, and we know that she's struggling with addiction. So based on just this little bit of knowledge, she would qualify under the individuals and families experiencing homelessness population of focus. And we list some of the criteria for that below. In addition to being at risk of homelessness or homeless, we also need to make sure there is some type of physical, behavioral health, developmental need that Pamela needs to have addressed as well. So in this case, for Pamela, her addiction issues would help qualify her for ECM. Any questions on this case study? Are you all ECM experts now?
Actually, I do have a question. Sorry, this is
Great.
Anastasia Snyder.
Hi,
So I'm looking at this and I just want to clarify. So bullet point number 1, living in a supervised, publicly or privately operated shelter. So that's a survivor who's living with us, correct?
Could be, yes.
So in which case she does not need any other, there's no and to that because she is residing in shelter, correct?
So how it works, and I should probably clarify this in the slide, is we have to establish what is their homelessness issue.
Right.
At risk of being homeless, experiencing homelessness, and that could be bullet number 1 or bullet number 2.
Right. So what I'm saying, though, that was my clarifying question, is if she is residing in our shelter, so the privately operated or publicly operated shelter,
Yep.
then we don't need that. That establishes her, correct? Because she's
We
in a
still have to
shelter.
have that and. We have to have that complex physical, behavioral health, developmental need that she would benefit from care coordination for.
Okay, thanks.
Sure. Great question. Thank you. Anybody else? All right, we're going to jump into community supports. So ECM community supports are 2 separate programs the state has rolled out. We mentioned that ECM is a Medi-Cal benefit, and community supports are optional services that Medi-Cal managed care plans can offer. And so what we've seen across the state is some managed care plans in some counties offer all currently 14 approved community support services. And in some counties, we're only seeing that maybe there's only 6 or 8 community support services. And that often has to do with what services are currently available in a county. Can they support community supports capacity, all this good stuff. So we see a variety of different community support services being offered. Sometimes plans in the same county can offer different community support services. So it's really important to understand which community support services your plan is offering. And I know that Baljeet has dropped in a bunch of important links to help figure out what those community supports are. So community supports are optional services for Medi-Cal managed care plans to offer. As of January 1st, we have 15 approved community supports, though our most recent one, which is transitional rent, will not go live until the earliest July 1st. So we're not seeing that actually be operationalized quite yet. And then for managed care plans who don't offer all of the approved community support services, they can offer new ones every 6 months. So typically January 1st and July 1st, a managed care plan can add a new community support service or remove a community support service in case a provider has dropped out. So here are the 15 approved community support services. And the intention behind community supports is that these optional services, and they're considered in lieu of a Medi-Cal benefit service, will actually save money down the road. So we're trying to find ways that we can keep folks at a most appropriate level of care, lowest level of care for the things that they need, and keep them in the community at a lower cost. And keep them healthy. So we're really trying to target what social determinants of health we can with community support. So we have a lot of community support services focusing on housing services. So looking at how do we help folks access housing. You guys do housing navigation, a lot of you, I'm sure, and that is a community support service. We also want to make sure that once folks are housed, they get support in staying housed. And so that becomes our housing tenancy and sustaining services. So we want to try to get folks into housing, keep them housed. If they need help with a little bit of money to help pay their deposit, to help them get their utilities set up, we also have housing deposits that are going to help them with those types of services. And then we also have other services that are really trying to target other pieces of the SDOH. So if we look at medically tailored meals, we know folks who are diabetic may need a boost in terms of getting the nutrition they need to stay healthy. So we can actually get folks meals that may help them become healthier over time. So we've broken down our community supports and go through them into different groupings. We'll talk through a bit more detail what they are. But I do want to just point out a couple of things about how do we access community supports to make sure that we can see it's very similar to ECM, but there are different referral processes and of course different referral forms to get folks into community supports. So again, the state would like to see all community supports referrals come from the community, come from the providers who are working with these individuals, because we know what they need best, and we can help make the referrals for the most appropriate services. So the state's really pushing that. We also know that individuals and their families can also refer themselves into community supports. And then we do see still a lot of managed care plans are identifying folks who could benefit from housing, from other community support services. So those referrals are coming through. And across the state, each plan is a little bit different in how they do community supports, and they all have slightly different forms for community supports, which are supposed to be on their websites. But we really have to make those referrals to the managed care plan to get them approved before they get referred on to a certain organization for housing or any other services. So we've broken down the community support services into kind of bundles here just to help us talk a little bit more about community support services. And so our first bundle is going to be our housing services. And there are many different types of housing services the state has approved. We talked about 3 earlier, which you may be doing as you work with folks who were in shelters. But we also have a few other housing services through community supports that can be helpful. One is recuperative care, medical respite. Someone comes out of the hospital, they don't have a safe place to go, but they still need to recover from their surgery, from their wound, whatever it may be. They can get recuperative care, medical respite services through community supports. We also have short-term post-hospitalization housing. Often folks go from the hospital to recuperative care and then to short-term post-hospitalization housing, trying to help them become healthy before they go back out into maybe an unstable housing situation. And then our newest community support is transitional rent. It was just approved by the federal government in December. It is going to offer up to 6 months worth of rent for qualifying individuals. We don't have a lot of information on who's going to qualify for transitional rent, but we do believe it's going to be tied to behavioral health. Because the intent is that folks will get transitional rent through community supports and then be able to get rent assistance through Prop 1 dollars that we passed last year and get funding through that funding stream as well. So we're still waiting for more state guidance. We do know that some managed care plans can offer this as early as July 1st of 2025, but that it will be required for all managed care plans to offer through community supports January 1st of 2026. Our next bundle of community supports is going to, oops, I went too far. It's going to have a couple of different pieces here. The most popular community support service is actually in this bundle, medically tailored meals. We have seen that be the most heavily used community support service. But other than that, we have day habilitation programs, which is looking to help folks who have who were homeless or who are at risk of becoming homeless, learn some skills to help prevent that, help to make them stable. We have sobering centers, asthma remediation, a few other things like that. And then our third bundle is looking at folks who are really coming out of facilities and need to, step down into a more appropriate level of care, lower cost level of care, but still be stable. Any questions on these services?
Can you speak? Oh, sorry, this is Anastasia.
Hi, Anastasia.
Sorry, can you go back to the previous slide?
Sure.
Specifically, day habilitation programs, peer mentoring to improve socialization and adaptive skills. Can you talk a little bit about what that is specifically? I heard you, I'm wondering if group therapy or individual therapy would fit into that, or so I'm just curious. That's
yes. Great question. Yeah, absolutely. And so day habilitation, that just is really becoming more important as we started to see a lot of success come out of these programs, is trying to give folks the skills they need to live independently and live successfully. And so it may not be group therapy per se, but it could be learning how to live in a group environment. It could be learning how to use public transportation, how to do money management. There's a wide range of trainings and skills that qualify under day hab. But it's not necessarily going to be group therapy per se. It would have to meet certain criteria. And I think we have more details. I know, Belgique, you did put in the policy guides, and you're way ahead of me, putting in what can be considered as part of DayHab here. So yeah, just looking at how do we help folks become successful at living independently. Would some of these things qualify under your group therapy sessions?
Maybe not therapy, but maybe some of those things, daily living skills. But I would see that being more within the shelter setting, not necessarily outside of the shelter setting. So,
I like how you're
yeah.
thinking though. Yeah, I think managed care plans are actually really hungry for day hab programs because they know they work, but they don't have a lot of providers who do them. And so I think there's been a lot of push to figure out how do we get more of these types of training programs set up to really help folks. So something to think about. Anybody else have questions? All right, we're going to see if Pamela qualifies for any community support services. So again, Pamela is a survivor that's living in your shelter and struggling with addiction. So again, as we did with ACM, we have to make sure that Pamela can qualify for community supports. We have to make sure she's enrolled in Medi-Cal managed care and not Medi-Cal fee for service, and that's really important. And we have to know which health plan Pamela is enrolled with. And then for community supports referral, we have to figure out what community support service she would benefit from and that she would qualify for. And of course, every managed care plan has a different referral form for each community support service. So you do have to know going in which one you're going to refer Pamela for. And so it's important to look at that and to think about what would Pamela most benefit from? And sometimes, especially with the housing community support services, there's often an order the managed care plans like to approve things in. So they may want to approve housing navigation for someone who's currently living in a shelter before they approve housing tenancy and sustaining services. We want to help her find a housing unit before we help her stay in her housing unit. So looking at how do we do that? We also know for community support services that oftentimes there are some limits, whether they're once in a lifetime benefits or if some of these services actually come with dollars attached, there may be some dollar limits for these services. So being aware as you're making referrals for folks you work with, is this a once in a lifetime benefit? Is this the right time to use that? Or are there other resources we should be looking at pulling in to help that individual get housed, stay housed, whatever it may be, without jeopardizing these once in a lifetime community supports benefits. Questions on this? Right. Well, we're now going to look at financing. Again, my favorite section here is looking at how do we get paid for ACM community supports? How do we consider this as part of our budgeting cycle? And can this be sustainable for us as a funding stream? So we'll jump into all of that. One thing that is sometimes challenging, and again, it's not consistent across managed care plans in every county, but what are the payment models being used for ECM and community support? So I can cover today what the common ones are. Now, each managed care plan does things a little bit differently, but generally speaking, that we are seeing for most ECM and many community supports, we are seeing managed care plans pay on a per member per month basis, so bundled payment. So let's just say you have 5 folks that are enrolled in ECM with your organization. You're going to be paid, let's say, a rate of $500 per month for each of those 5 individuals. And the managed care plan will require that you engage with them, you touch them, provide a service to them once a month, twice a month, 3 times a month. It varies by managed care plan in order to get that payment. So if you think about this and you look at the types of folks you're working with, if you have someone who is a very high need individual and may need to have 8 or 10 engagements per month, per month can be a very expensive proposition for you as an organization to do. Or you may consider that as being, how do we balance our caseloads to make sure that we have both high need and lower need folks in ECM so that we can make this per member per month bundled payment work for us. Another model that we're seeing for some community support services, and some plans are using this, but not very many for ECM, is what's called a fee for service payment model. So you're being paid per service, per day, or per a time period, so maybe a 15-minute increment. And so we see for our respite care, our recuperative care, we're often having providers being paid for a 24-hour period for having someone in their bed. And then we also see for some community support services, we want to make sure that you're being paid for the service. So if you actually did a housing navigation service, you're being paid just for that service for that individual. And the third most common payment model that we see is a cost-based reimbursement. We only see this with a few of the community support services like housing deposits, where plans can pay up to $5,000 for things like getting hospital beds into a housing unit, for paying deposits, first and last month's rent, those types of things. And those are really where the organization has to spend the money first, of course, have the receipts, and then submit those for reimbursement to the managed care plan. So we're seeing that a little bit here and there. We're also hearing across the state that some plans are moving to more of a value-based payment model, but we haven't seen that be rolled out very widely across the state yet. But I think as more plans and more providers become efficient at doing these services, we'll start to see more and more of those payment models come into effect. If we look at ECM and community supports, one of the things, I'm sure you've heard this as well, is that it's a steep administrative burden to jump into ECM and community supports. There's a lot of things you need to purchase, a lot of training your staff needs to go under to really become effective at doing these programs. And so the state has set up different funding streams to help with startup costs, to help with getting the technical assistance organizations need to really do these programs effectively. And there's 3 that we've thrown up here today that are the big ones. I'm sure there are many others that you may be aware of. These are the big dollar ones right now. And the first one I'm going to talk about is Pass Cited, because this is a grant program that the state runs. It has been incredibly impactful in helping folks jump into ECM and community supports, expanding their services. So it's been really great. And we're actually in the middle of the last round of funding for Pass Cited right now. The applications are open and they close March 7th. But these are grants that, and they go up to $1 million, but they, and even more. They really help organizations purchase equipment like electronic health records. They help you hire more staff and do staff training. If you need a vehicle to help transport folks to different services, you can use Pass Cited dollars to do that. You can also use Pass Cited dollars to work on renting a new office space, a larger office space to have all your new staff. You can purchase, computers for all your staff with Pass Cited. It's a really great way to invest in your startup costs or your expansion costs for ECM or community supports. So, but you have to be either a contracted provider of ECM or community supports or intending to contract. So if you are thinking about jumping in as a provider for either ECM or community supports, I strongly encourage you to look at Pass Cited, knowing that it is the last round of funding the state's going to do through this pathway. And again, the grants can be pretty large. The average for a 2-year funding cycle has been $1.1 million. This current round, our last round, is a 1-year funding cycle, but they have not put an upper dollar limit on what you can request through Pass Cited. So check that out if you're considering becoming a provider. The next funding stream we'll talk about is also through PATH, and that is the Technical Assistance Marketplace. And this is a very unique situation where you, as an organization who either is an ECM or community supports provider or wants to become one, can get consulting services paid for by the state to help you do this. So it's free to you. The state pays your consultant. And it has a wide range of things you can get consulting services for. It can be data support, it can be contracting, it can be writing your policies and procedures, it can be helping you with workforce development. There's 7 different domains they fund for consulting services, but the key piece is that it's all free for you, but it has to be tied to ECM or community support services. They have a whole marketplace website set up. It is a bit clunky. It's not the easiest thing to access, but it really is a great way if you do need assistance in either entering into ECM or community supports or expanding or improving your services. The TA marketplace is a really great funding stream to take advantage of. And that is going to be open for folks to use through the end of 2026. The last funding stream we'll talk about today is called IPP, the Incentive Payment Program. This is a little bit different than the PATH funding streams. PATH is paid for directly by the state. IPP is done through the managed care plans. The state gave managed care plans some dollars they could use to really build capacity and infrastructure for ECM and community supports in the counties they work in. And so most plans have spent down a lot of their IPP dollars. We still hear about a few funding streams that are out and available for providers through IPP. So again, if you are either already a contracted provider or want to become one, talk to your managed care plan about IPP and see if there's any funding available to help you do the ECM and community supports work. All right, those are the big funding streams. Any questions on those? Past cited again, last round of funding closes March 7th. The state has put a bunch of webinars up on their website, which Baljeet dropped in the chat, that answers a lot of questions, gives great guidance, and they have one more webinar coming up on February 3rd. If you are interested, I would encourage you to check that webinar out.
I have a question. This is Anne.
Sure.
From
Hi,
Dallas. We're an organization that offers this sort of housing navigation and assistance finding and obtaining housing. And we do that for people who are in our shelter and also those that are not in our shelter, but we're working with outside of that space. So if we're interested in receiving CalAIM funding, and I feel really dumb asking this. So you're suggesting that we reach out to our managed care programs. Is that correct? If we want to apply for any of these funds?
Yeah, so I think that the first step is, do you want to be a provider? So let's say you do housing navigation for folks in your shelter, not in your shelter, helping them find housing, helping them stay housing once they find that housing unit. Those are community support services. So if you wanted to become a provider, you would need to contract with your managed care plan to become that community supports provider. So that's the first thing. If you want to take advantage of these 3 funding streams that are up on the screen, you would either need to be contracted with them or have an intent to contract. And they would have to submit what they call a letter of attestation for past cited, for example, saying, we've talked to Anne, we're working on the contract. Yes, she can apply for past cited, she's eligible. So that would be, if you're thinking about doing that, you want to be a provider, you could then take advantage of these 3 funding streams.
So here in Butte County, we would contact the partnership. Is that correct?
I believe it's partner. Is Kaiser also in Butte County? Okay, so it's just partnership, yeah.
Okay.
And so I know that partnership, they're looking for providers, of course, you know, in some of those rural Northeast counties, they're still needing providers for pretty much every service. So I would definitely reach out to them. And then I know that partnership does have some IPP dollars left, and they'll be making an announcement at the end of February where they're going to be targeting those IPP funds too. Yeah, so one of the things I think is really important, and again, I'm breaking down silos, all the CalAIM goals and everything, is getting to know your managed care plans because they are going to become really important players in the county and healthcare and social services going forward. The state is really driving a lot of change, a lot of funding through them. And so I think getting to know them, whether you want to be a provider or not, is going to be important to do. So we can talk more about that and some of the things that I encourage providers I work with to really do to get to know them. And partnership is a great MCP. They're really invested in. So I would encourage you to start to reach out to them and build those relationships with them. And then let's talk about blending and braiding funding. This has been a hot topic for pretty much everybody who's thought about becoming an ECM or community supports provider, because we know that ECM community supports is a new funding stream. But unfortunately, for many folks, that alone is not enough to be sustainable for the services you're doing. So we have to think about how do we bring all the different funding that's available to us together to really make our organization, our service stream whole. And so what we've learned, and again, this is a kind of a Medicaid rule, a Medi-Cal rule, is that ECM and community supports can supplement but cannot supplant existing services that are funded through other state, local, or federally funded programs. So we have to think about if we're already, let's say we have a grant from our county to do housing navigation for 100 people. We can't have community supports come in and take over the housing navigation for those 100 people, but community supports could allow you to expand your housing navigation to serve 150 people, for example, or 200 people. So really looking at how do we capitalize and bring different funding streams together to serve more people, to serve them more effectively, to offer new services that may benefit the folks that we're already serving. So really thinking about the funding in that way. And we also know that ECM Community Supports is really bringing in a bunch of what Medi-Cal considers non-traditional providers into these areas. And so how do we blend and braid Medi-Cal with our social service funding? That's a big question, and we'll talk more about that in a minute, but really thinking about this and thinking, how do we set things up from the get-go to make sure we don't supplant dollars, that we don't double dip, that we are clean for an audit. So I encourage folks to really do a lot of thinking around this before they start billing for ECM or community support, so we don't jeopardize either of the funding streams you're utilizing. The big one is going to be CalOES that we have to talk about today here. So how do we make sure we're not billing the same service to both CalAIM and to CalOES? And how do we identify what's separate? Like, how do we make sure that we can identify and have documentation to get through an audit, that this is billed over here to CalOES and this is billed to community support services? And so one of the things that we've done a lot of talking to different folks. We talked to CalOES and thinking about how do we do this in a way that's going to get us through an audit. And one of the things that we've really thought about is on the functional timesheets, how do you define the services you're providing? So can you allocate between case management versus crisis intervention? Do you have different staff that are doing community support services versus your other services? How do you start to separate that funding so that we can ensure that we're not double dipping, we're not supplanting, but we're still maximizing our funding opportunities? And I know, Allison, you had brought up that it might be a great idea to really outline how to separate funding sources in your CalOES cost allocation plan. So just from the get-go, we're being upfront about how we're doing this. I don't know if you want to expand on that at all.
Yeah, I think when we talked to CalOES, they didn't know a lot about CalAIM and how domestic violence organizations could interact or become providers for that. And so, they had a lot of questions around, are these services the same? What does that look like? And so I think just to, again, ensure that you're clear for an audit for your CalAIM services, just making sure you're clear for an audit from CalOES as well. And so just making sure everything is clearly articulated within your cost allocation plan would probably be a good idea. Great. All right.
And I think, Allison, at this point, I'm going to turn it over to you for the rest of our sections here. So for our considerations, I will leave it up to you.
All right. Thank you. All right, so this last piece of our webinar, we really wanted to talk about some of the main points that you should think through when you are deciding if your organization wants to become a provider for CalAIM. And so we're going to talk a little bit about the administrative components you need to think through, about your staffing, about data sharing and confidentiality, and then about some of the startup costs, and looking at those and comparing it to your revenue potential. All right, so administrative components. So as Gretchen mentioned earlier, some of the administrative startup can feel like a really heavy lift for organizations that have never done Medi-Cal billing. And so some things that you really want to think through are IT platforms. And so I know a lot of the databases that domestic violence organizations use may or may not be able to transition into CalAIM services simply. And that's because not only do you need to document the work that you're doing with the MCP member, but also you want to think about how you are going to bill for those services and create claims, and then also report out your services to your managed care plan. And so when you're looking at an IT platform, it needs to be able to kind of do all of those three things. And a good place to start really is to talk to your managed care plan and determine what requirements they have, what platforms they may use, what platforms may be available to you for use as you're kind of determining what it is that your organization needs to do all of these things well and accurately for billing purposes. And so one thing to also keep in mind is that here coming up pretty soon, they are going to require a closed loop referral system. And so what that means is that there's a system where you as a provider say, oh, wow, this Pamela could really use some supports from this other community service. And so you would be able to make the referral through that system. That other community service would get that referral and then could acknowledge they received it. And then, they set up a meeting, all of those sorts of things just to increase communication. And so that's what we mean by a closed loop referral system. And so again, whatever IT platform you're thinking about, just making sure that it has all of the components that are going to be required by your managed care plan. And so again, when Gretchen talked about the funding that's available, so those cited funds or those IPP funds could help you with the initial cost of the startup of these IT platforms that you may choose. You can also, there are a few EHRs that are out there now that are really specific to CalAIM that may be a great place to start, and that kind of does all of these components all in one. And so really thinking through, do you need like kind of like a traditional EHR that's been used for medical purposes, or do you need something that's really more specific to CalAIM? And so some organizations I know are billing for therapy services already with a therapist. And so what the EHR that you need may look really different than an organization that is going to be providing only community supports, and that's the only billing that they're going to be doing. And then just keeping in mind that there will be constant staff training on all of these different platforms. So you'll have, of course, the onboarding of a new platform, the training for all of those, and ECM, what is it? How do we do it? The platforms that we're using. And then you're going to have turnover. You may expand your program. The state or the MCP may change how things need to be done. And so just kind of thinking through, how do you build in staff training as you kind of continue? So it's not just a startup cost, but it's just going to be kind of a continuing piece. Gretchen also mentioned the quality monitoring and oversight. And so your managed care plan will be able to specifically tell you kind of what that's going to look like and what they want to see when they're doing this quality monitoring and oversight. But generally, you want to have someone that is overseeing the program, making sure that you are following all of the requirements from DHCS, following all of the requirements of the MCP. So you just make sure that you are in compliance and that you're receiving the dollars for the work that you're doing, and you have the appropriate backup documentation. Another thing to consider is a hub. And so when we talk about a hub model, if you were outside of a hub, your organization would contract directly with your MCP. And so there would just be, the straight line of oversight and communication. When you enter into a hub model, there's kind of a third party there. And so you would contract directly with the hub model, and then the hub model would contract directly with the MCP. And so the nice thing about this model is that it does, being a part of a hub takes away some of that administrative burden. And so the hub is taking care of the claims and making sure everything comes back clean and then paying out your organization. And so an example of that you all may have heard of is the Full Circle Health Network. So when you're kind of trying to think through what model might work for your organization and trying to think about financially what might be possible. This is just something to consider. It may or may not be the best for your organization, but definitely something worth looking into, because some of these hubs also have like an EHR that just kind of comes with it, comes with the model. And so there's a lot of administrative things that may be reduced for your organization. And we also wanted to just mention again, Kaiser has a different model, and it's similar to a hub model. And so your organization would not be directly contracting with Kaiser, but instead you'd be contracting with a national lead entity, which kind of plays a similar role. It's a bit different, but again, you're going to be contracting with this lead entity rather than directly with Kaiser. All right. You want to go to the, all right. So staffing. So when you're thinking about your staffing, you really kind of want to think about um, how many folks are you going to be able to provide these services for? And do you need more staff? Can you use existing staff and kind of break up their job duties? Some of the MCPs may specify specific numbers that they would like you to work with within your contract. And I know when I first started doing this work, the ratio was 50-1, which seemed absurd to me. I was like, wow, these are folks that need high touch. Working with 50 folks in 1 month feels like you may not be able to do a great job with all of those 50 individuals. And so a lot of providers are now using a more trauma-informed approach and looking at a caseload of more like 25-1. And so again, this might be a place where you need to talk to your MCP and do a little bit of negotiation of what's gonna work best within your own organization. You also want to think through what combination of licensed versus non-licensed staff are needed. And so we haven't really talked about CHWs or community health workers in this webinar. We'll talk about it in a later webinar, but CHWs require a certification in order to do the work. But for ECM and CS, there is no required certification to provide those services. However, you still want to talk to your MCP about if they require someone to oversee the program that does have a license. That is really common with ECM. And so just making sure that you're talking to your MCP to really determine what kind of staffing that you are going to need to be able to provide these services successfully. And then again, just thinking through all the staff that the kinds of staff that you might need. So you might, have case managers or advocates that are ready to fill in this role. Your organization may have CHWs on staff already. I think you probably all know that having staff with lived experience can really support the folks that you're working with someone who has kind of walked the same path. Also thinking through how are you going to really supervise this program? Do you have a program manager that can oversee it within their current duties, or are you going to need to hire someone else to kind of oversee the whole program? And then thinking about your administrative staffing, and do you have someone on staff that has done Medi-Cal billing before? Do you have a finance person that can easily take this on, or do you need to hire someone else to specifically support your Medi-Cal billing? And then think about outreach staff. So some of the work that you're going to be doing is reaching out to folks that could benefit from these services. And so again, like, do you need to hire folks to be doing that outreach, or can that already just kind of fit within the staffing that you have? So, all right. So data sharing and confidentiality. I think this is a really big conversation for domestic violence providers. And I think that there's still some pretty big open questions out there. But we really wanted to make sure everyone was aware of all of these different pieces so you can make as informed of a decision as you can moving forward. So, as an ECM or community supports provider, the informed consent is really important. And I know you all do that in your work currently. Um, but again, a lot of domestic violence agencies haven't interacted with this Medi-Cal system. And so, what does it look like? First, I think it's important to talk with your survivors about where their information might go in the CalAIM context. And it could really differ between MCPs. So it's a really good conversation to have with your MCP to kind of decide how you talk to your survivors about this. Um, I reached out to Anthem to just ask them, like, who gets to see this information? And they said the MCP nurse and the care team would definitely have access to that information, and that anyone else who had access to the provider portal, so it could be, a doctor or a therapist, could have access to that information, but they're under HIPAA regulations to only access members' information should they have a medical reason. But we all know that someone could still access it without a good reason. So it's just these things that are important to understand and be able to explain to a survivor when you're working with them. And just knowing that all of this information is going to go into a survivor's record. And there, you could, so your document retention requirements for Medi-Cal is 10 years. And so you could have an audit that goes like 10 years back. And so just kind of trying to think through what that means specifically for your survivor. So, for under your regulations for VOCA, VAWA, and FIPSFA, you're required to have time limited releases. And so, is 10 years time limited? What does that look like within this context? Because at that point, the MCP and DHCS could view the records of anyone that you worked with. It's also good to think about those ROIs or releases of information. So generally, when you're a provider, you're using kind of like a universal ROI. So they're saying like, yep, I'm going to sign this. You can talk to anybody that's going to help me, on this ECM path or the CS path. But again, according to the VAWA, FIPSFA, and VOCA regulations, you need to have specific releases. So this is also going to be a conversation with your MCP. And so as you start moving forward with this, what we really recommend talking with your MCP to see if you can use a specific rather than a universal ROI with your survivors. And another way to protect your survivors' confidentiality is to never mention anything about domestic violence in any of your notes or anything that's going to go into their medical record. And so, a domestic violence survivor is not a population of focus. So it never actually needs to be said or written anywhere. And so one thing to note, though, if your organization only works with survivors, and in their medical record, it shows that they're receiving ECM from a domestic violence organization, then someone could then deduce that this person is a domestic violence survivor, whether you ever say it or not within any of their records. And so as you're thinking about being an ECM provider, and if you follow through with that, just as a part of a safety plan with your survivors, is just talking through do they know anyone that works at the MCP, at the managed care plan? And then, if they would like those services, and maybe they do know someone at the MCP, maybe you're not the right provider, and maybe you need to refer them to another provider. So as it can never be deduced that they are perhaps a domestic violence survivor. Right. Do you want to go to the next slide, Gretchen? Thanks. Okay, so then we want to talk a little bit about the startup costs and the revenue potential, because I think aside from confidentiality, this will be another important thing to think through before becoming a provider. And so payment, what that looks like is it is really important to submit clean claims to your MCP, right? So if you submit a claim, there's a time period in which they are supposed to pay you, but if it gets kicked back to you because they're missing information, um, or the service wasn't authorized, all of those sorts of things are really going to slow down the timeliness of the payment coming back to your organization. And it's also important to do invoice reconciliation so you can see what you're getting paid for, what might be missing, and just so as you are starting this process, really just improving your systems so that you are submitting clean claims and getting payment very regularly to support your organization. Um, so there is this Camden Coalition revenue estimating and budget tool that Baljeet put a link to in the chat. And this is a great tool that kind of allows you to determine what sort of revenue could be produced by being a ECM or CS provider. And so it has a revenue planner that allows you to put in, the rates that you were going to be receiving for your ECM or community supports. It allows you to incorporate multiple MCPs if you have multiple plans operating within your county. And then if you received any sort of grants, whether it's cited, IPP, or something else, it allows you to incorporate all of those pieces of revenue within this tool, as well as helps you kind of think through all of the expenses you might have. So what staffing are going to be involved with this? What are the office expenses, your administrative overhead, the IT platforms? So kind of putting this all into the tool, and then it'll help you kind of determine what revenue you could actually bring in from pulling these programs, become a provider for these programs. And one thing that is really important is to think through, your revenue cycle management. And so, what we mean by this is making sure you have a process and system in place from intake all the way to, your claim submission to working through your claim denials, and then eventually coming to payment. And so making sure all of those processes are clearly laid out and all of the procedures are really followed so that you do have a really good cycle of revenue coming into your organization and there's not a lot of kind of hiccups and slowdowns to payment along the way. All right. So then, what are your next steps if you are considering becoming a provider? So one, even if we step back a little bit from that, really just determining how you want to engage in ECM and community support. So whether you become a provider or not, a lot of these services could be really valuable for the folks that you work with and helping them find sustainability in their own lives and thriving outside of an abusive relationship. And so you can engage in this in multiple ways. So you can become a provider and provide these services directly to the folks you work with, or you can become a referral partner. So building relationship with the MCP, getting to know the organizations that are providing these services within your community, and then being able to refer folks for these services to another provider. You want to get to know your MCPs. So I think we've mentioned that multiple times. There are some MCPs and some communities that are not taking on new providers for one either ECM or some community support because they have quite a few. And so you don't want to get too far into the process and find out they're not taking on providers for housing community supports. And you want to know what the requirements of the MCP are and MCP are, so you can really figure out if this is going to be a good fit for your organization. And then again, take some time to do a cost benefit analysis so you kind of know what you're walking into. Being able to separate the startup costs from your regular monthly expenses and how much revenue are you going to be able to bring in as an organization. And then something I feel pretty passionate about is really thinking about how entitlement programs will impact your agency and the folks that you work with. And so what I mean by that is that currently how most of your organizations probably run are whoever walks in the door can get any of the services that you provide, no matter their income, no matter their insurance plan, all of those sorts of things. And in my work in the domestic violence field, that is something that felt really important. So everyone could receive the same services. But it's just good to note that, in entitlement programs, that's not how it works. So someone has to be a Medi-Cal member and qualify for these services in order to receive ECM or housing supports or whatever it is. And so just really thinking through as an organization how you want to approach that. And so, maybe as an organization, you decide that, yep, only if they qualify for these services will they receive these services. Or you could, create a policy that really just says, things haven't changed for us. Whoever walks in the door can get access to these services. We just get to bill for some of these services as well as the others we don't bill for. We just offer these services. And so I just really think taking some time to be thoughtful about how you approach this work and how it could shift your work if you've never had any sort of entitlement programming at your organization. And then lastly, join your county's collaborative planning initiative. And so these are regional groups that meet on a monthly, I think it's a monthly basis. And it's a time for you to kind of understand if there are any changes happening with your MCPs, to connect with other providers in the area. It gives some time to allow for regional planning for services, help you kind of think through any sort of implementation issues that you're running into. So it's really just kind of a great supportive group. And so we'll put a link. LG put a link into the chat. So if you want to figure out who your CPI group is for your county or counties that you work in, then you can join those just again to learn more information and to connect with other providers. Okay, so there's been a lot of information. I think before we move on, we just wanted to stop and see if there were any other questions you all might have. You can put them into the chat or unmute and ask. And we will, I think Baljeet mentioned in the text, we will send the slide deck out after the webinar. So if you read back through it, go through some of the links, and then questions pop up, you can always reach out for this to us as well to ask those questions. Okay. All right. So thank you for attending this webinar today. Baljeet put a survey link into the chat. We would love to get your feedback about this webinar, but also about questions that you might still have, barriers that you're foreseeing, things you would like to learn about CalAIM. And we wanted to let you know about some upcoming sessions that we have already planned, and there will be more information coming out soon. So as we mentioned, Path Cited is open and will close on March 7th. And so we are planning a webinar for February 5th to kind of go over what Cited is, what the application looks like, and just kind of support any of the organizations that are interested in applying for Path Cited. And then following that, on February 10th and 25th, we'll have some Path Cited office hours. And so these will just be sometimes if you're working on your application, you can pop in and ask any sort of questions that you might have about your application in general or very specific. And then we have two other webinars planned. So one will be February 21st, and that one will dive a little bit deeper into ECM community supports and community health workers and how those programs coordinate between healthcare and social services. And then on March 11th, there will be another webinar on credentialing, what that process looks like with your MCP, opportunities for support, and general billing guidance. All right. And so with that, that brings us to the end of our presentation. And so we really look forward to working together with more of you all in the coming future and to seeing more of you on our webinars. Um, yeah, so I think that's it. Gretchen or Baljeet, do you have anything else to add?
Thank you so much.
Yeah,